Chris, talk to us about informed consent in pain medicine. This has been a topic that, lately is becoming more frontline.
I think informed consent, that I like to call treatment agreement, is a wonderful opportunity to educate your patient and to re-educate your patient on a periodic basis. So in getting back to the basics, basically opioid pharmacotherapy is based on biopsychosocial indication. You need to pick the right person for the treatment itself. It needs to be a recognized pain model that has been shown to be responsive to opioid pharmacotherapy. And then you tell your patient what the alternatives are, what the effects are, and what the potential complications are of opioid pharmacotherapy. And that's pretty much inherent within your treatment agreement and within your informed consent. Now, within the informed consent, I'd like to sort of go over it with the patient just about every month to every couple of months or so to remind them that this is something that they need to be responsible for, and there's certain expectations that I'm expecting from them for them to continue on the opioid pharmacotherapy. And I would say the predominant one is compliance and being with the program, and really accepting the whole program, and that is part of the informed consent. And that is pretty much agreeing to the opioid pharmacotherapy as well as to the non-opioid part of the plan, including physical therapy, psychotherapy, as well as telling them that at some point, if we find that their pain scores are not diminishing, if their function is not improving, if they're not meeting the endpoints that we agreed on, which are mostly function focused, that there could be an exit strategy here. We may actually gradually taper off the opioids because there has been no material improvement in their day-to-day function. The pain that they were reporting to me before the opioid therapy is continuing after the opioid therapy. So that kind of puts them on notice that for us to continue opioid pharmacotherapy, they need to physically and materially and socially and functionally benefit. And that's the purpose of treatment agreement, as an initial introduction and as an ongoing reminder.
You know, Chris, I'm glad you bring up this concept of exit strategies, because there's one area where I think, especially primary cares make a huge mistake. It's so easy to start patients on opioids, and it's easy to get them tolerant to escalating doses, but it's almost impossible to get them off opioids. So I agree with you, having that conversation up front and repetitively, saying, hey, listen, this is like any other medication, whether it's blood pressure or diabetes or cardiovascular. If you don't fully respond, this might not be the class of medicine for you. We're going to stop it and try something else.
You know, one other thing I wanted to add, Chris, I think it's critically important they understand the social responsibility they have when they're going to receive an opioid. Because there's one area that I think we have not paid enough attention to, things like safeguarding your opioids. So these are some of the things I'll discuss with my patients too. You want to make sure that they're appropriately stored, that there's not access. And it's important, I think, to not in this sense interrogate your patient, but to definitely inquire about what the living situation is at home. Do they have a bunch of teenagers that are in and out of the house? Are multiple families living there? Is there a way to safeguard your medication? Because the problem, if we look at diversion, implicit or explicit, we know that medications are getting out into the market. So these type of social responsibility, the call for that on the behalf of the patient, is extremely important.